how do you think this trend is going to change over time? So, next-gen sequencing wasn't very prevalent before. You say it's more. Do you think it's still restricted to mostly academic centers, community centers? What do you see as the overall trend in next-gen sequencing?
I think the trend is towards doing next-gen sequencing in the community more and more. And I share that because, 10 years ago when I started my career, it was rare that we would even see any kind of outside mutational testing when we saw a patient from the outside to our clinic. It is an exception if we do not see now patients who come into our clinic looking for a trial who does not already have a next-gen sequencing profile already completed by their community oncologist or oftentimes requested by themselves. And so I think this is a trend that is continuing, and the recent CMS announcement that they will pay for at least some NGS sequencing would suggest that trend will continue. And ultimately, I think it comes down to this issue of cost, right? We said in 2002 it's $2 billion.
Right.
NGS sequencing, I don't exactly know the exact cost right now, but I think if you get Foundation or something, it's a couple of $1,000s. But once this cost, I think, goes down to a couple of $100s, I think you're going to see people ordering this and without any major denials from insurers. And I think it's going to become a routine part of all cancer care patients, whether metastatic or early.
So right now, though, what you're saying is that it will expand, more companies will come into the fray and then drive the cost down, and then it'll be much more affordable. So hopefully more payers will pick it up and pay for next-gen sequencing. Now so most of the next-gen sequencing, just to be clear, is done in stage 4 patients with metastatic and solid tumors, not in resected, let's say resected colorectal or something. We don't end up doing next-gen sequencing on the resected tumor.
Correct.
Because essentially you are not going to change your treatment based on that currently.
Correct. I think that's where vast majority of next-gen sequencing is being currently used right now.
No.
And I would say in the community and to some extent in most in the community, most patients they get a next-gen sequencing once they've failed standard chemotherapy. In the academic setting, obviously there are initiatives to bring NGS earlier, whether it's in the neoadjuvant setting or even frontline setting for certain tumor types, and many of our colleagues, as you know, are looking at that. But I think in the community, at least, it appears the vast majority is oftentimes after they've failed standard chemo.
So after whatever stage 4 cancer, they've had 1-2 chemotherapies or some kind of tyrosine kinase inhibitor therapy or something.
But I think it also depends, as you know, on the tumor type. Increasingly non-small cell lung is kind of being divided up into different
the pot is getting smaller and smaller,
smaller of different subsets of tumors, and now NTRK, RET, ROS, ALK-ROS, BRAF, et cetera. And so in some sense, it's more economical for community oncologists to go ahead in that frontline setting to go ahead and order NGS. Colorectal, some would argue that, and some other tumor types, et cetera. But I think the vast majority of other cancers, I think people are not really ordering it until after they've failed standard chemo.